the website individually to get credit, and that helps us maintain these services as well. So definitely important. So today it's my pleasure to introduce Dr. Katherine Silva. Dr. Silva joined us by way of University of Florida in Meharry for medical school. She's a champion of underserved patients and also Spanish-speaking patients, and she's going to go serve our community here in East Tennessee with Cherokee Health after graduation, and I think she'll be a great asset for them, and she's been great with us. And today she's going to talk about a topic that's near and dear to her heart, cultural competence, and I will turn the floor over to her and leave the room so she can take her mask off.
Okay. I'll take my mask off. Thanks, Dr. Dodd. Thank you, Dr. Dodd. He's my advisor, so he's awesome. So today I'm talking about cultural competence in pediatric medicine. I'm going to minimize my face so I'm not staring at myself the whole time. Chime in if anything goes wrong with the PowerPoint. All I can see is my slides. So I'm Katherine Silva, pediatric resident here at ETSU. So let's go ahead and start. I have nothing to disclose, no conflicts of interest. So first I thought we could start off with a case. It's a case we might see in our clinic any day of the week. An 8-year-old male from Mountain City, Tennessee, which is pretty close to us, going up for a hospital visit. Let me go ahead and mute this because everyone's joining and it bings every time. Let's see. Oh, I'll deal with it. So it's a hospital follow-up for recent acute asthma exacerbation. His history is just pertinent for mild persistent asthma. Otherwise, he's a well child. He had a circumcision that went well at birth. He's on fluticasone and inhaled corticosteroid for his controller medicine. And albuterol as needed and Singulair for some seasonal allergies along with his asthma. His father has asthma. His mother is healthy. His mom and dad in a mobile home in Mountain City. He's got 2 siblings. And someone saying something? And he's in 3rd grade and is a good student. There are no smokers in his home. So what are some additional questions that people might be interested in asking to kind of elaborate? People can chime in, and if no one does, I'll just start saying things. Any other questions?
What kind of home do they live in?
Yeah, so they live in a mobile home, an intact family. That's a good question. I would start to think of things like, does anyone else help take care of this child? Or, you know, even things like homes. Anyone have any other things they want to add before I move on? Okay, then I'm going to move on, but we'll get into some, here are some things that I would ask. So what pertinent questions would you want to ask his family? Or these are categories. What additional social history do you need to gather? And what are some possible barriers to his asthma care? So this presentation will get more into good interviewing techniques to dig into some of the cultural or subcultural differences that we see, not only in this area, but in all different cultures. So things to think about are, what is your underlying belief about what's wrong with your child? What do you think is causing this asthma? What do you, what do you know about asthma? What are you most worried about in regards to his asthma? So, and then it's okay to ask a family, what do you think we should do about it as physicians? What do you want to see us do to help your child? This opens up some discussions about home remedies, and the more you talk to a family about their child's diagnosis, the more you're going to understand how much education they need to understand the pathophysiology of their child's disease. So this is a quote that I really liked. It's kind of complicated. It's from an author who wrote a couple different articles I read. It says, what is cultural competence? It's an acknowledgement and incorporation of the importance of culture, assessment of cultural relations, vigilance towards the dynamics that result from cultural differences, expansion of cultural knowledge, and adaptation of services to meet the patient's unique cultural needs by clinicians and healthcare systems. So when we talk about what is culture, so culture is defined as the pattern of human beliefs, values, and behaviors that are inherent in different racial groups and different ethnic groups and different religious groups or social groups. And then social groups can be anything. You can categorize people based on age, what generation they belong to, how able-bodied they are, what by diagnoses. There's all different ways to categorize social groups. And characteristics, behaviors of these groups, which help them become their own group, are things like shared thoughts, shared language, shared beliefs, and shared institutions that are consistent throughout that group. And you can have variations across cultural groups, even from people from the same area or from the same ethnic background, because of immigration or because of family structure. Individuals in a family can influence the family dynamics. Education has a big effect on, social group, and then socioeconomic status, of course. So this is just breaking down the quote. So it's important to acknowledge the importance of culture because it's all around us, and many people we interact with have different culture than ourselves. It's important to assess how different cultures interact and be aware of our differences. We want to avoid being ethnocentric, thinking that our own culture is what's most normal or what's most good, and also being aware of, the understanding that people tend to have a mine versus theirs mindset. And in medicine, it's our job as physicians to get away from that a little bit. It is our job as physicians as well to expand our knowledge of the patient's culture because it does influence their care, and to adapt services to meet the patient's unique cultural needs. So one of the ways we do this that's pretty uniform throughout all the articles I read, which was a lot of articles, talks about doing QI projects or surveys to get feedback that help adapt services to improve outcomes in all variety of cultural and ethnic backgrounds. So historically, cultural competence didn't really start appearing in the literature until about 30 years ago, and even more so in the last 10 to 20 years. Other terms they'll use talking about cultural competence is cultural effectiveness, cultural humility. Key principles in all of these are empathy, being able to be, emotionally put yourself in someone else's place. Curiosity, which is being interested in things without being interested in someone else's culture or someone else's life without taking offense on their differences. And then respect, being able to see differences and appreciate differences. So the goal of having a better cultural competence is really greater understanding and appreciation of the social context of our patients and understanding our own cultural biases and how it might affect our care of our patients. So in service of improving communication, increased cultural competence will improve our communication with our patients, which ultimately gets to the main goal of better clinical outcomes, better adherence to the treatment plans we suggest. And it is a process more than an end goal. Nobody's ever going to be perfectly culturally competent, and we all have our natural biases from our upbringing and our own ethnic and cultural backgrounds. So it's more that we are all striving to be better than trying to be perfect with each interaction. So why is cultural competence important? Well, in our country, there are rapidly changing demographics of the US pediatric population. So in the 1800s, even into the early 1900s a little bit, we had mostly European and English-speaking immigrant populations immigrating to our country. But In the last 100 years, there's been a lot more variety: Hispanic, African, Asian, Caribbean immigration, and even within our own, cultures in the United States, regardless of immigration, we have subcultures that we have to understand. We live in a region with its own special subculture, and children are really the fastest growing immigrant population. So as of this, sorry, thought I heard something. As of this year, as 2018, more than half of all children belong to a minority group. So, hey, I think someone's logged in and not muted. It might even be my baby. Hold on. Someone's not muted, but I'll keep going. So, the Hispanic population are the largest minority population at this point. So it's very important to us as pediatricians to understand that we'll be seeing more than half the children we'll be seeing will belong to a family with a minority background. Okay, so here's a good bar graph that illustrates the racial and ethnic profile of children under the age of 15. Far right, you can see that the dark blue are white children, and then we have the Hispanic children are the kind of light blue, yellow is other, and then African American is gray, and then Asian is this medium turquoise type blue. So what it's showing is that as time has gone by in the last 40 years, white children have actually become a minority. There's less white children, or less than 50% white children now. So minority children are more than half of all children under the age of 15. So that's incredibly important for our pediatric practice to understand that. And here's another bar graph that shows a prediction of the future racial and ethnic profile of US children, and how by 2060, the composition of children will be only 36% white, up to 32% Hispanic, and 14% African American. So, our pediatric population demographics are changing, and they're changing during our lifetime. Here's an interesting chart that shows the trends of immigration of children with families. So, and it goes back to 1850 on the far left, as you can see, and then up to 2018 on the far right. So the purple line is the percentage of immigrant families, and the blue line is the absolute number of immigrant families and over time that have come into the United States each year or each decade. So in the last 50 years, you can see that we've had a rapid rise of immigrant families with children coming into the United States, and that influences our demographics, as we've seen with the previous percentiles. Here's a cool map. It's just showing the most common languages spoken other than English and Spanish based on all of our 50 states. So in Tennessee, you can see that it's Arabic is the third most common language spoken, which I thought was interesting. Actually, my grandpa grew up in North Dakota only speaking German until he was about 12, and German is actually the third most common language in the Dakotas. You can see Chinese over in California, and down in Texas, it's actually Vietnamese. So I thought this was very cool, so we can kind of understand how things vary across our own country. Here are some charts that I just wanted to show because it actually has our state on it, Tennessee. It's just showing the top 5 states by absolute and percent growth in children with immigrant parents. So, and it shows it for 2 different sets of decades, from 2000 to 2010, and then from 2010 to 2018. And you can see here that in 2000 to 2010, Tennessee had the greatest percentile growth of children with immigrant parents than any other state in our country. So I thought that was impressive. It means that we have, in the last couple decades been affected by large influxes of immigration. So what are some reasons that people might immigrate? There are obvious reasons, and I listed some of them here. We can read through them. Escaping a war-torn country, usually we call that a refugee. Escaping a violent culture in the home country. Oftentimes that's an asylum seeker. America has amazing educational opportunities and economic opportunities, or oftentimes families immigrate to be close to family that has previously immigrated. But ultimately, it's important for us to understand that parents are immigrating to find a better life for their children. So that's an important kind of background to understand. So here's another slide, just continuing on why cultural competence is important. It's by a man, there's a quote on here by a man named Glenn Flores, who's a pediatrician, and he's an expert in this area. And he writes a lot on a lot of articles and does studies on minority children and health disparities. So minority children do have worse health outcomes than white non-Hispanic children. I'm going to go ahead and read this quote by Glenn Flores. Although minority children outnumber white children in the United States, racial and ethnic disparities in children's health and healthcare are extensive, pervasive, and persistent. Children's disparities occur across the spectrum of healthcare, including in mortality, access to care, use of services, prevention, quality of care, and organ transplantation. So in Dr. Flores, he really has done multiple reviews of literature. We'll talk about one of his later where he compiles hundreds of studies. And really every review of literature that he and the American Academy of Pediatrics has done supports this statement. There's a lot of health disparities between white and minority children. Here are some stats that we can run through that just illustrate this. So I kind of categorized it by ethnic background. So in African American children, they have 44% higher asthma rates. They are hospitalized for asthma up to 3.6 times more than white children. Their mortality from congenital heart disease is almost 20% higher. And the age of a heart transplant, controlling for other factors, is 5 years older than white children. For Asian and Pacific Islander children, they have a 2 to 3 times higher likelihood that they will not have seen a doctor in over a year. And then there's one study that I briefly looked over that just showed a 50% higher mortality rate for Hawaiian children age 1 to 4 compared to mainland white children. And for Latinos, there's a 3-time higher birth rate between 15 and 19-year-olds, and there's a higher risk of death from ALL. This is just a couple things I picked out of a large review that had hundreds of statistics, all kind of relating to this. And it's all very complicated. It's a complicated issue. I mean, there's many factors that contribute to these disparities. There's poverty is a big one, geographic factors like a lack of cultural sensitivity, even racism at times, language differences. But ultimately, these are things that we as physicians should address. But it is very complicated, and the factors that play in include different levels of involvement of the individual, the family, the community, and our health systems. But ultimately, like I kind of said with the last slide, the American Academy of Pediatrics has done a lot of extensive reviews and found very consistent results relating to these disparities. And cultural competence is just one small factor, one small piece of the puzzle that we can be aware of and that we can self-improve on to help close this gap between help close these gaps and get rid of some of these disparities. So some consequences of cultural differences are listed here. Variations in perceptions of what causes illness or what an illness does to an individual. Various patient-clinician encounters and dynamics. And Dr. Jay Shanker and I were just talking about body language during a clinic visit and how it does, there's a expected body language from a doctor in the United States that may be different in other countries. Different approaches to personal health care, and family involvement in personal health care, and then differences in timing for when help is sought out. The immediate thought I had for this differences in timing for when help is sought out is really with the prenatal visits. In a lot of countries, women don't go to an 8-week prenatal visit. They are caring for the baby, they're taking precautions, but they don't see a doctor till later, and it's not necessarily inappropriate in their culture. Our ultimate goal for improving our cultural competence in healthcare is better patient satisfaction, better patient safety, and improved health outcomes. And that's very important to all doctors, I would hope, and for pediatricians especially. So one thing that I think is a good practical start is just talking about medical interview techniques that help really dig into all these different aspects of a patient's life to better understand their cultural context. So, our goal is to understand social context, our patient's literacy in general, our patient's health literacy, how our patient understands their illness, which is called the patient explanatory model for illness in a couple of these articles. Our job is to also understand how family members and community members influence our patient's health care, and to understand what alternative medicine our patients are using. And then the second part of a good medical interview technique is to be able to negotiate a treatment plan that the family will understand and be willing to follow consistently. So there's a great article that breaks down how to kind of go through an interview like this. And here are some examples of questions, and we'll go through each of the different parts. But initially, it's to figure out how your patient thinks about their illness, which is called the explanatory model. So there's questions like, what do you think has caused your problem? What do you call it? Why do you think it started when it did? What worries you the most about your problem or your illness? What kind of treatment do you think would work? And, maybe in some cultures it might seem like the physician isn't taking charge, isn't able to figure things out on their own, but that's not the point. You can have a very distinct diagnoses in your mind and treatment plan in your mind, but to understand where the patient is in their understanding, it does take asking some of these questions. The patient's agenda is what we do with every visit when we ask a patient, how can I be most helpful to you? Or what were you hoping to cover today? Those are just some practical questions to make sure you don't go through a visit and miss what the patient was actually there for. Some cultures and some individuals are more comfortable speaking outright and addressing the doctor with that, and some need a little bit of prodding and need to be asked specifically. So it's important to include that. And then illness behavior is asking things like, have you seen anyone else about this problem besides a physician? Have you ever used non-medical remedies or treatments for your problem? And then who else advises you about your health? And this will give you a lot of information on those alternative medicines, on who in the family has a big influence on your patient's health care. The second part of a medical interview is getting more of the social context of the patient. It's called the social context review of systems. And we actually screen for a lot of this in our social determinants questionnaire. So we don't necessarily have to go through and ask each of these individually at appointments because we've screened for it already. But then we do address it with our behavioral health team when one of them is flagged. But some of these questions is just asking about money. Is money a problem? Are you ever short on food or clothing? Are you able to get to all your appointments? Can you keep track of them easily? Do you have a phone where we can reach you? The change of environment and environmental changes that's mentioned there talks about understanding where the patient came from. So when are you from here? Where are you originally from? What made you decide to move? What brought you here? And then how have you found life to be here versus where you came from? And then talking a little bit about social stressors, finding out what support systems they have, what family they have nearby, whether they're involved in a religious group. And then literacy and language is more, we screen for that as well. Just making sure they can understand enough to read notifications that may come in the mail, or asthma action plans that we're sending home. So it's a very important part of the medical interview. And then the next slide is how to overcome cultural and literacy differences and negotiate a treatment plan. So first, we do what we've already done. We explore the patient's explanatory model for their illness, and then we, analyze how it's different from the actual biomedical model that we understand. We try to describe our biomedical model in understandable terms, and at that point, we determine the degree of the patient's understanding. And then if conflict remains, we can reevaluate core cultural issues and reevaluate social context. Many articles talk about bringing in people from the community, like religious leaders, or people from the family, like grandmothers and grandfathers who may have a central role in that family, bringing them into the clinic to have them be involved in the explanation and understanding of the illness, because that will help the child and the parents be more invested. Okay, so to make this a little bit more interesting, we're going to go through some specific examples of cultural influences in pediatric medicine. So I was going to do infant feeding, introduction of first foods, obesity, and then puberty. So for infant feeding, we deal with this a lot in our pediatric clinic. A mom comes in with a newborn baby. We talk a lot about breastfeeding. We talk about bottle feeding and pumping and all that. So we as pediatricians know that unhealthy infant feeding ideally is breast milk and a delayed introduction of complementary foods. Now that's not always possible, but that is what's considered ideal. So looking at some of the breastfeeding practices based on race, there is a variation. Caucasians, the article it's exclusive breastfeeding up to 3 months, I believe. So 43% of Caucasians, 40% of African Americans, and up to 75% of Hispanic mothers exclusively breastfeed up to 3 months. One thing I found very interesting is that the longer and the more generations, the later generations of Hispanic mothers, the longer they're in the United States, the less they exclusively breastfeed. So, but regardless of socioeconomic status, Hispanic mothers breastfeed almost twice as much as any other race. And then foreign-born mothers do have higher rates of exclusive breastfeeding regardless of racial background. One thing I found very interesting that was in actually 2 different articles were taboos against colostrum. So we know that colostrum it's that initial milk that is being produced right after the baby's born, and it's low volume. It has a little different color. We know that it has very good immunologic and nutritional benefits. But it does have this a yellowish color, and is different than usual breast milk. So some cultures believe that it's not good for the baby. So many different countries, and it's not generalizing for the whole country, but little subsets in each country will use different types of honeys, herbal mixtures, sugar waters in the first few days of life until the mom's milk fully comes in. I have a couple examples I wrote down, but there was a long list. But in Durango, Mexico, they often use 30 different herbs and give it to the baby for the first couple days of life because the milk is muy fuerte, meaning too strong for the baby. In Vietnam, there's some subsets that will give ginseng herbal tea and boiled sugar water for up to 3 full days after birth. And then several African countries use a water-based feed with sugar and some milk and some salt and honey. So, of course, in America, you know, in our community, most babies are born at the hospital and they wouldn't be allowed to do that. But it is good just to understand, you know, where people are coming from and some of their hesitancies. And we all know, like we'll talk about in a little bit, the next line is that honey is just not safe for babies because of the risk of botulisms. So a lot of these cultures that are using honey in little babies, just, you know, we need to be able to address that in our initial visits, even in the hospital, before the family goes home. A big part of many cultures, which I don't know if it's a huge part of American culture, is the postpartum support, where many cultures have this intensive family support for weeks to months after birth. And the initial month or so after birth really protects the infant from the evil eye, or like the shadow. There's a couple different names for it in a couple different languages. And it's to protect that newborn baby and that new mom's milk from this evil eye. And families will help feed the new mother and baby, isolate them from society. And if a mother is here in the United States without that support, it may be very disturbing for her to not have that. And then some other kind of general things I just wanted to mention, just going back to Hispanic children who do have higher rates of breastfeeding. There's a couple different mentions in the articles that just say that this higher rate of breastfeeding in Hispanic children might actually help explain the better health outcomes despite socioeconomic status for Hispanic children. So we can move on. So what can we do as pediatricians? We can do early breastfeeding education, even starting in OB/GYN office, starting with our first visit with the baby in the newborn nursery. And then we can talk about breast pumps, because I don't think many other countries are using breast pumps as prevalently as we are. And a lot of immigrant moms just aren't familiar with it. So kind of educating the moms on how to use them, how to store milk. We do a lot of that in our clinic. Recognizing and praising the cultural traditions that value breastfeeding. There's actually references in the Quran about breastfeeding up to 2 years, so praising cultures for the really cool breastfeeding practices they have, and then recognizing the fear that does cause overfeeding, and by doing that, by providing appropriate nutritional education. So one example is just that Somalian mothers tend to supplement with formula despite good breast milk supply. We see that a lot with our Latin population here too, just to produce a chubby infant, because out of the fear that there might not be enough at some point, or that they're not providing the ideal nutrition for their infant. And all of this can be overcome with spending time and educating these families. One thing to mention too about breast pumps is just that we don't, they're a lot more necessary in our country because of the early return to work and the busier school and work schedule that you might see here than in a home country. And so in order to continue breastfeeding, you may rely on a breast pump. The next subject is the introduction of first foods. So the first group, these are all directly from this Pat Gorstein article that had a lot of cool little bits of information. He did a lot of surveys, and he surveyed African American moms, kind of asking them general questions about first foods. And a lot of, so what he looked at is what one group said a lot more than another group. So what African American moms said a lot more than other groups is that they felt like they needed to add baby cereal to milk early on, even when the baby's like two months old, not just for GERD, just for general increased nutrition. That they would oftentimes give additional food because they were perceiving their child as giving them hunger cues, and that the moms had a desire to share good food with their babies. So they wanted to share what they were eating with their child. And then also a concern for their baby being too small and not feeding them enough. In the Hispanic population, there tends to be an early introduction of meats even before 4 months, pre-masticated even, and fruits and fruit juices. So those are things that we need to address early on to try to push back a little bit and help families understand why it's not recommended by the AAP. There is something that's called no come nada, which is if you ask a Latin mom, what is your child eating? She may say he eats nothing. And you really have to get into exactly what was served for breakfast, what did he eat, what was served for lunch, what did he eat, because there is this desire to just to provide a healthy and provide enough food for their children. And so we have to be able to get a good history from these moms to be able to educate them correctly. In Somalian cultures here in the United States, there's a distrust of canned baby food. This was figured out in a survey that Pat Gorstein did. And really it's because the baby food's sitting unrefrigerated on the shelf. It does look totally weird. And then we serve it to our little babies. So, having a good understanding of how people are making baby foods at home, that's important. Some other practices are that were kind of throughout multiple different cultures is this parental control of feeding. The AAP recommends allowing babies to self-feed once they start eating some solids. And there are many cultures that will, feed the baby the amount they believe they should be fed. And this can lead to overfeeding. And then I already mentioned the pre-masticated food, which is not something that's a huge deal, but it's just something to understand that some cultures will chew up food and then give it to their baby so they can more easily swallow it. So what can we do? We can discuss the delaying of solid feeds at the 2-month visit. Way before the baby should be getting any solid foods, we can talk about introduction of first foods and juices and all that, and kind of introduce the parents to that. We can ask about other people in the family and feeding the infant and who usually feeds the infant. We can understand the basic principles about baby food preparation like I talked about. As pediatricians, we can advocate against the high calorie formula substitutes that are given to picky eaters who have appropriate weight gain. There are toddler formulas. There's like Leche Niño. There's all these different formulas you can buy for even 2 and 3-year-olds that are high calorie. They have high sugar, and we need to be able to educate our families about that. We can advocate for WIC to include healthy and culturally appropriate food choices. The next subject is obesity, which the WHO calls one of the most important public health issues. It's defined as a BMI over the 95th percentile. Historically, in the early 1900s, the children in poverty were thin and wealthy children were more obese. But since the 1990s, you can see that from these statistics, 37% of poor children are obese compared to 24% of non-poor children. And this is a pretty consistent, I've cited Graham, but this is a pretty consistent statistic throughout multiple articles. It's a huge problem in our country. So this is a bar graph that shows the prevalence of obesity among youth aged 2 to 19, and it's separated by sex, race, and Hispanic origin. And what you can see is that the prevalence of obesity is much higher in African American and Hispanic children. We can look at the total. We don't have to break it up by gender because it's really the same pattern mostly. But if you can see that the dark blue bar is the non-Hispanic white children, the lighter blue is the non-Hispanic black children, the darker green is the non-Hispanic Asian, and then the lighter green is the Hispanic. So Hispanic children are the 25.8% of Hispanic children between the years of 2015, 2016, and it really hasn't changed much, are obese. So, and looking at the Asian children, the non-Hispanic Asian children, they have a much lower degree of obesity in that racial background. However, There are specific studies done on heart disease in Asian individuals, and heart disease has actually correlated with lower BMIs in some of those Asian races. So just understanding the risks for your individual patient is really important. Here's another chart that's just showing the obesity prevalence, that obesity prevalence decreases as income increases usually, but this is not consistent across all races and ethnic groups. We'll just look over here on the left, we'll look at the boys column. We can see that for the total, the dark blue bar is a higher income, the green bar is the middle income, and the gray bar is the lower income. So as with the lower income, you have higher rates of obesity. But if you go down to the non-Hispanic, Black, and Mexican American sections, you can see that the middle income actually has higher rates of obesity than the lower income. So it does vary based on income, but that's not consistent across racial and ethnic groups. So obesity is a complex problem as well. There's lots of things that correlate with obesity: lack of insurance, being raised in an urban community, public insurance, smaller family, obese parents, single parents, older parents, parents with low education. It's very family dependent. So what can we do? We can do what things we're all already trying to do in clinic: continuous counseling about nutrition and physical activity. We can monitor growth at regular health supervision visits and have more frequent follow-up appointments for those who are struggling with morbid obesity. We can advocate for targeting low-income and minority populations to prevent and treat obesity. And then we can advocate here in our community for healthier school lunches and increased. Touch on puberty just because I think it's kind of interesting and I'm on my endocrinology rotation, but the Tanner stages are actually based on British school children in the 1950s, all white, and these norms don't always apply to every person perfectly, even white children, but it is a norm for the majority of the children that were studied. So the one specific thing that I found was interesting in these articles is just that like a Tanner 5 staging requires hair on your upper thighs, but Asian and Native American children might never get distribution onto the upper thighs even when they reach Tanner 5. And then a study of initial breast development in 17,000 girls in America found that between ages 7 and 8, only 5% of Caucasian females were showing breast development, but up to 15% of African American girls were showing breast development. And the really interesting thing is that studies in African countries did not show this same early development in girls. So what can we do? We can be aware of our limitations of our established growth charts and Tanner staging. We can counsel parents appropriately about the developmental stages of puberty. We can educate ourselves on racial differences of growth and development. And we can learn how particular ethnic groups based on our patient base view puberty and how they discuss it in their home. So what can we do at a systems level to improve our cultural competence? There's multiple articles on this too. There's some general consensi and everything. So I'm pretty much listing what I picked out to be the most interesting and important. One thing that was mentioned across many articles was just hiring practices that prioritize diversity. So you can have clinic staff that have a diverse background. Posters and education in multiple languages is very inclusive. Cultural competence training of all staff that's kind of continuous and throughout their working life there. Having interpreter services, of course, and then having case conferences that relate to cultural competency. So when something happens in clinic that's either interesting or caused a problem, everyone can get together and talk about how a cultural and ethnic background affected that. At the medical school and medical education level, there's this one study, the Rule et al. Study, that surveyed medical students and residents and attendings and really assessed they did a self-assessment on cultural competence, so how culturally competent they felt they were. And what increased feeling culturally competent was working with underserved groups and clinical experiences. And another thing we can do, just like the interviewing technique that we already talked about, which is in the Carrillo article, talks, educating and starting to teach that interview technique in medical school, which I think we get some of at this point. And then the more and the better the cultural competency training is, the more people feel able to address patients from different cultural and ethnic backgrounds. Some individual resources, there are some great resources at the end of these articles. I picked out 3 of them just to share, but there's a website called Culture Clues. It's through the University of Washington. It includes these neat cheat sheets that you can see over on the right here, where you click on a cheat sheet and it pops up little facts about that culture and the language and things that you might see little stereotypes, and it helps you work through how you may interview that patient or some of the roadblocks you might come up against. That's a cool resource. Another is Diversity RX, where it's more of a resource database. So you go here to find cultural competence training, or there's a big article database, and it's got tons of resources. And one of the leading resources for cultural competence, they're a leading mind in the country regarding this issue, is Georgetown University. So they have a great website. They have self-assessments, which are currently down until June, or else I would have stolen one and done it. But they have a lot of resources. They have a huge website. And then there was something called the USDHHS National Standards 2001, which are national standards for how to create a culturally competent clinic. And it's some of the same things we already talked about, like a diverse staff, continued education, provide good language services, provide written notices in preferred languages, use of official interpreters, and then ongoing self-assessments. And these are ways to best to do our best in a clinic setting in regards to cultural competency. So going back, kind of shifting gears, thinking back about our initial case from Appalachia, our beautiful area that we live in. And we got to think about this little 8-year-old boy. He's got asthma, and kind of try to understand what barriers to care he might have. We know that there can be a lot of barriers to care in our area. And so there's some general statistics I'm going to throw out there, and then we're going to talk about all the wonderful things about this area too. But in this area, 57% of adults aged 25 to 44, so a little more than half, have some type of post-secondary education. That's compared to 63% of the nation as a whole. So there's a little bit lower amount of adults in this area with a post-secondary education. And then, so that kind of goes along with the general literacy. With health literacy, it's related to general literacy, but it really comes out as you ask the family what they understand about asthma. The community involvement in child rearing, that's something that's very cool about this area. It's very tight-knit communities, very tight-knit families. It's very important to understand who's raising the child. So in the case of this 8-year-old who lives in a mobile home with his family and does not have smokers in the home, I just imagined asking the family, who else helps raise the child? And so, well, Mama and Papa live down the street in their own trailer, and they both smoke, and the child does spend weekends there. So he actually does have smoke exposure. Even though they're very loving, nurturing grandparents, smoke exposure can affect asthma. So being able to kind of tease out some of those specific social contexts is very important. So, and another, sorry, I got distracted. So social context related to poverty and living conditions is very important. In our region, up to 25% of households are living in poverty. That's compared to only 15% in the nation as a whole. We have 10% more people living in poverty than in the nation as a whole. So asking things like, how do you heat the trailer during the winter? Is it kerosene? Is it electric? You know, how are you heating? Kerosene can affect lung health. It can be an irritant for the lungs. So we actually had a patient that we really dug in and found that it was probably the kerosene heater that was causing his asthma to flare in the winters. One of my attendings who's from this area mentioned agricultural exposures. Overall, living on a farm makes you less likely to have allergies, but for those kids who do have asthma, living on a large animal farm can make your asthma a lot worse. So understanding some of those things. And then some special considerations based on population, thinking about dental health, thinking about transportation. So I wanted to end the talk just to do some shout outs for strengths of this region. We deal with a lot of cool communities in this area, and some things I've learned. I've only been here 2.5 years, and I have this, I'm glad I don't have to leave because I've really bonded to the area. But this area is really an Appalachia, you know, it's labeled as Appalachia, but there's a lot of strong community bonds. It's cool how the communities here incorporate nature into their daily life. And this includes the farming culture. I mean, right now, farm to table is trending in the nation as a whole, but really Appalachia did it first. And so that's a really neat part about this area, healthy, you know, eating vegetables and fruit straight from the ground and the tree. It's a very independent and hardworking culture. So you see that through the parents of the children we serve. And then Mamaw and Papa, I put exclamation point because this I'd never heard before moving here, and it took me a while to get the names right, but now I'll never forget Mamaw and Papa. It has a strong meaning for me because Mamaws and Papas here are the center of the family oftentimes and have a huge influence, and I really respect a lot of the Mamaws and Papas that I see in clinic. The kin versus outsider, I just put in there because I think that's an interesting dynamic in this area. I'm not going to go into that in depth. And then a faith-centered community where there's a lot of strong emphasis on faith and God. And then, of course, we can't forget the bluegrass music that everyone loves. But I just wanted to end on that. Here are my resources. And I hope that was a little bit of fun information for y'all. It was a pleasure doing this presentation. And thank you.
Thank you, Katie. I know typically we would all clap at this point, so it is different doing it on Zoom. Thank you for an awesome presentation. I think it's time for questions. We have a few minutes for questions. Does anyone have any questions? Please unmute yourself to ask.
Hi, Katie. This is Will Dodd. I just had a question. First off, that was an excellent presentation. I thought that was great. I just had a question about using the interpreter in a system like we have in clinic. Do you have any tips for building rapport when you have to go through that sort of intermediate step in terms of communication?
So that's like a whole separate talk. I honestly could have done a whole talk just on interpreting, but there is a couple little tips of which I think we all kind of know, where you keep eye contact with the family, even though you're talking to the phone or the video. So you're directly addressing them rather than talking to, and it's very hard to do. Like I find myself looking at the screen, talking to the interpreter and have to redirect, but making sure that it's really centered on the family. We had an interpreter for a mom that was hard of hearing, and he would not make eye contact and would explain looking at the ground because he felt that strongly that the family needs to be the people we're connecting with. So that's probably the one thing I can think of.
Great, thank you.
You're welcome.
Other questions?
Katie, this is Dina Alshanak. I just want to say thank you. This was a great presentation. Definitely enjoyed it. I know you had mentioned using honey in some cultures early on, like especially if they're breastfeeding.
Mm-hmm.
I just wanted to add that in some cultures from the Middle East, they actually take the inside of a date and put it inside the baby's mouth, the newborn, in the first 2 days if the mom is breastfeeding. And
Wow.
it's an unsafe practice, of course, but it is very, very common. And I've had a mom ask me about it, and I didn't know how common it was. I thought this was done just in, years past, but apparently some folks still do. But that was definitely interesting. I didn't know that other cultures also practice that. So thank you for shedding a light on that.
Yeah, I thought that was a really interesting part of the articles. Thank you, Dr. Dina.
Katie, this is Varun Kumar. Very good presentation. Thank you for that. And I can tell you did a lot of research into this. I had a question. Some of the earlier slides, the health disparities, especially health outcome disparities among various races. I think right now we're seeing it with COVID seeming to be disproportionately falling on the African American populations due to being more urban and more population dense. But in our area here in Central and South Appalachia, as you know, it's predominantly Caucasian.
Right.
In those outcomes, do you know how much they controlled for socioeconomic? Because I don't know any data or evidence, but I would guess that some of the health outcomes among Caucasians in this area are similar to some of the worst ones that you showed in terms of race, even though they're Caucasian.
Yeah, no, that's actually something I should have said. There's not a lot of good studies on just Appalachian children and their health outcomes over many, many different areas. It's mostly like the newborn period in the couple articles I saw. But I would agree with you that the children in our area, although they're Caucasian, do have some they also have a lot of barriers to healthcare and are seeing some of these same difficulties. So yeah, it's just that there's not the biggest articles, and the ones that compiled hundreds of studies just don't deal with the children in our area. That's why I didn't use them for, I mainly focused on the data that I did have from the major articles, but I agree with you.
This is Dave Wood. Can I make a comment?
Of course.
The Dr. Kumar's question. There are many, many studies looking at disparities, and the disparities range across almost every health issue. They very commonly, almost always, try and adjust for other factors other than race or ethnicity or language that might explain the disparity, like poverty. So almost every statistic where we say, African Americans are 3 times more likely to present to the emergency room, oftentimes those are very sophisticated studies trying to even look at the severity of asthma to adjust for it. So as well as poverty, maybe even housing characteristics. So they do a lot of work to try and tease out some of these factors, but definitely things like poverty, which are more concentrated in ethnic minority populations, contributes to those differences that we see in outcomes.
Thank you.
Great. Thank you, Katie, and thank you, everyone. If there aren't any other questions, let me remind everybody to please log on to the CME website, complete your evaluations. That keeps us in line with being able to continue these sessions and to offer these grand rounds. Thank you, and have a great afternoon.
Thank y'all.